We've got quite a lot to update on today, but the focus of much of our discussion this evening will be about inclusion, and we've thought that it would be most helpful for you to hear from some of our HEE colleagues. So tonight you will hear from a range of people. We've got Professor Namita Kumar, who's one of HE's postgraduate deans and the co-chair of the HE Postgraduate Dean Group. We've got Dr. Harpreet Sood, who's one of HEE's non-executive directors. We've got Jonathan Corn, who's a postgraduate dean in East Midlands. We've got Dr. Hatim Abdul Hussain, who's a GP trainee who has worked in HE as one of our fellows. We've got Professor Geeta Menon phoning in from the Trust down in London, who's one of HE's postgraduate deans. And we have Dr. Sanjeev Ahluwalia, who's another postgraduate dean from London. So I'm hoping that tonight will answer lots of your questions, but also give you some insight into how we think about inclusion issues in HEE. So to start off, I'm going to hand over to Namita to update us on one of the issues that we've had lots of questions and comments coming into HEE on, which is training in the private sector. And Namita has been following that up for us. So over to you, Namita.
We need to make sure that every training opportunity available is available for you, and we're doing our best to do this. And one clear message has been the whole system wants to do this too, across the NHS and across the private sector. So we're working really hard, and of course the colleges and the academy are also involved. You will need some of the usual regulation, and so there are a few key things that we'll have to make sure that are right, so it keeps your training safe and it keeps you safe. So postgraduate deans will need to approve the moves. Your postgraduate dean will remain your responsible officer. The independent provider sites do need to be approved by the GMC, and this is happening already across England and the UK. So there is a bit of process involved, and it's not new to us. We are on this, making sure it's done in a timely way, as is the GMC. You need to be on a standard programme. We wouldn't want people doing things they wouldn't be normally expected to do. The supervision arrangements must also remain in place. And we are working on some of the detail with regards to how the move goes from the trust that is overseeing the work to the independent sector. We are really hopeful that we'll be able to produce some guidance that we're working on jointly, and so keep an eye out for that. But the message here is we're committed to this happening for you. We don't want to delay your training. We want you to have all the skills you need, and watch this space. So that was all I had to say on the independent sector. So back to Shona.
Thanks, Namita. So if people have any further questions that they want to ask, if they pop that into Slido. Now, I'm sure that some of you will be more aware of how HE functions as an organisation than others. But one of the things we have in HE as an arm's length body is our board. And Harpreet is one of our board members, and I'm going to pass over to him.
Thank you, Shona. Good evening, everyone, and thank you all for joining us. So my name's Harpreet Sood. I'm currently a board member at Health Education England, but I'm also a GP trainee in North Central London. And so I'm hugely interested and excited to be hearing the trainee voice with our discussions this evening. But I also just wanted to share a bit of background of my role and what I've kind of been up to. So I've spent the last 5 years training less than full time, but within that time I've been working at NHS England, firstly as the senior fellow to the CEO of NHS England, and then was the Deputy Chief Clinical Information Officer at NHS England, where a lot of my role was around bringing the clinical world with informatics and thinking about how do we get the NHS more digitised and ensuring there's a clinical perspective. But during that work, a lot of my time was also spent on really understanding the workforce and thinking about digital skills. Is how do we upskill our workforce, in particular, helping them think through some of the digital transformation efforts we need, but also making them understand about data informatics and really thinking about how can we transform care enabled by technology. And one of the things that led to that from that work was the creation of the Nhs Digital Academy, which is one of our flagship programs that we host, which essentially trains chief clinical information officers, but also chief information officers, ensuring that we develop a cadre of professionals that can really take this agenda by its horns and deliver on it. And we're now running in our third cohort, so we have 100 cohorts per year. And then on the back of that, with the TOPL review, which again many of you may have come across, we developed the TOPL Fellowship Programme, which was again for mid-level clinicians across the system, and that's currently also being hosted from Health Education England. And so my role on the board is kind of threefold. One is to provide that clinical and voice onto the board and ensure we join up the dots and link up with all the relevant stakeholders, but also with the executive team members, and ensuring that we have strong clinical representation. The second is to bring the digital and innovation thinking into not only on how we deliver our educational programs, but also thinking about new skills and new curriculum. And then thirdly, to bring the kind of trainee and millennial voice onto the board as well, and to link up with the executive team. So those are kind of the three areas that I represent, and it's part of that inclusivity and diversity is also a key aspect of my work in ensuring that we can again join up with all the relevant work that's happening, but also position Health Education England as a employer internally, but also ensuring our trainees have all the relevant information, but also are included in all the conversations that we're having. And we have that inclusivity in terms of listening with them, engaging with them, and making a plan to make things relevant and appropriate for them. So that's kind of my work at Health Education England. Over to you, Shona.
Thanks, Harpreet. And it's interesting having a trainee on the board, and I think it's fair to say you've been welcomed by HE and by the other board members for the insight that you bring. Dr. Jonathan Corn, who's been working on this to provide guidance for trainees. And so, Jonathan, I'm going to pass over to you so that you can provide an update on where we are with this.
Thanks very much, Shona. I mean, of course, shielding is a national policy that applies to all workers across the spectrum, and indeed is coming to an end in August. But I think a much more appropriate way of thinking about it is in terms of clinical vulnerability. So some of you will be either clinically vulnerable or clinically extremely vulnerable in your normal clinical environment. And what for some of you that will be for a fixed period of time. For example, if you're having treatment that's making you vulnerable, or if you're pregnant. For some of you, it will be uncertain as to how long this vulnerability will apply. And indeed, some of you may even be worried about whether you're in the appropriate specialty. And our job, obviously, at HE is to support you during this time and to help you as much as possible in making the training decisions you have to make. And that's why we've produced this guidance, which will actually go onto our website under the COVID section tomorrow. Just very briefly, what this covers is it covers how we work with you to manage your training if you are shielding, how we work with you when you come back from shielding, and a little bit of stuff. It's not, we're not your employer, we're your training organisation, but we have had some discussions with NHS employers, and I'll refer to some of that at the very end. So as far as working with you during shielding is concerned, What we really have to do is make sure our educators can support you. So they can support you to gain non-clinical competencies while shielding. They can support you in many cases to acquire clinical competencies through, for example, virtual clinics or radiology reporting. And they can signpost you and help you in terms of well-being support. Now, what we have heard from a number of you is that whereas a number of you are doing really good things while shielding, very appropriate things, and having excellent supervision, some of you are not getting that. There's a feeling of being out of sight and out of mind. We've heard of educational supervisors make slightly inappropriate comments, such as, "Are you enjoying your holiday?" And so a lot of the document is about upskilling educators. And we have recommended that each region appoints a lead educator for shielding trainees who will be able to do that and who will be able to get involved maybe with signposting as far as some of the more difficult career advice is concerned. When it comes to return to work after shielding, what we outline in the document is a process by which hopefully before you return, you'll have a robust discussion with your educational supervisor or with an appropriate educator, which will include a discussion about your well-being, because we're very aware of the psychological issues and stress that shielding could have caused, where you can have the competencies that you have acquired signed off, where you can be signposted to the Return to Training Support Programme, and indeed to PSW and their services if appropriate. The other thing we would hope that would happen at that meeting is a plan would be put forward as to how you could catch up with your training. And the kind of things that we talk about are extending your training by a period up to the number of months you've had to shield for, use of OOPT, exploring dual site training. So, for example, some of the surgeons in our region are based at one hospital but are going to another trust to actually undertake certain procedures. I think I mentioned OOPT would be the other one. As I said, we're not the employer, but we have been talking to NHS employers. Of most immediate concern, I imagine, to many of you, what happens in August when the switchover occurs. What we've recommended is this is dealt with on a kind of case-by-case individual basis, but our expectation would be for most people they would benefit from staying in their current trust, simply because the difficulties of getting to know people, establish educational relationships in a new trust, having a virtual induction into a new trust would make things very difficult. So the expectation is most of you would stay within the trust who currently employs you, and that's been accepted by NHS employers. NHS employers have also accepted that the period of grace will apply to all of you, whether you're including those that are shielding. So I think that's an important piece of information. Finally, the other thing that we heard is that it's very difficult to get the relevant information. A lot of it is information from the government and from employees, and what we have committed to do is to work with you in the BMA and NHS employees to make sure all the relevant information is on a single website that we can signpost you to. Obviously things change, government policy changes, the guidance might change, but that's where we are at present. Hopefully that's helpful. And I'll hand back to Shona, I think.
Thanks, Jonathan, and for continuing to work with NHS employers. We have some questions that we will come back and answer at the end when we've got more of the Slido questions. So if you can continue to add them, and my Slido keeps cutting in and out. So if yours is cutting in and out, keep working with the system. So what we were going to move on to talk about now were the issues that we've been hearing about inclusion and diversity. And As many of you will be aware, the postgraduate deans wrote out to trainees. I hope that educators were aware that the letter was sent out from postgraduate deans and from me, asking what is it we need to pay attention to. Now, I'm sure for some of you this is frustrating because you feel that we should know, because there has been a lot of work in this space. And I think as a group that we feel that we are aware of things, but you can often believe you're aware because you haven't really listened. So what we try to do by asking for comments back was to open up our ears properly and make sure we were hearing the problems. Now, we've had lots and lots of responses, and they follow the same key themes. And so what I was going to do now is feedback some of what we'd heard, and the intention will be not just to feedback on what you've heard as say we have to do or think about, but actually to feed back to you in the future as to what we have done about these things. So one of the first things is we have to be careful in the use of the word BAME. Some people feel it's divisive, and that we have to be careful to separate out different issues for different groups. It's important to recognise that people are individuals and that people from different backgrounds will have different experiences. And we need to be alert to that and make everybody feel valued and included and make sure that everyone has a voice. We've also had a lot of reports that sexism is still a big problem, and that can make the other issues, if you add that to ethnic issues, considerably worse. There was a lot of feedback that you do not see representation at senior level, and we need to be more transparent about this. In HE, we are looking at this, working with NHS England and the RES team on how we could address that. But one of the reasons for having a webinar tonight is we do have excellent senior leaders in postgraduate medicine. And so part of tonight was to share that, because an awful lot of people had told us this wasn't visible. We also heard that mentorship or peer support for trainees would be helpful, partly to help those who might be struggling at some point due to difficulties with adapting to the NHS or getting discrimination from colleagues. And mentorship peer support can work two ways, with the reverse mentoring helping trainees who want to be champions to understand what the issues really feel like for people from different backgrounds. So we will very much look at how we can facilitate that. We have heard that it would be a good idea to appoint representatives of guardians to provide a listening ear or informal advice in the way that we have representatives or guardians for freedom to speak up. One of the other things we heard was that there should be training for staff and for trainees and others on how to deal with racism in the workplace. The bystanderism, what do you do when you see that there are racial problems in the way your colleagues are being treated? So we will look at how we can make you feel more confident, whether you're an educator or a trainee, in addressing that. We've heard from a lot of trainees that they've witnessed this as a third party and weren't sure how to manage it. We also heard that trainees can be scared to compromise their professionalism when calling it out with patients, and I think that's something we can work with NHS employers on, who are clear that they will not tolerate racial abuse, but I'm sure it doesn't feel like that if you're a trainee experiencing it. We've had a suggestion that we need to think about our teaching in things like dermatology to understand how things can present differently when you have darker skin, and we need to look at medical school and throughout postgraduate training that actually our education and training is cognizant of that. There was also a highlight that there is regular unconscious bias in our processes, and that there is probably frequent microaggressions that people are not aware of. So having regular training on that to make sure that staff in HEE and the other staff were aware of it would be welcomed. We've been challenged on how HEE and Royal Colleges are working to ensure that recruitment processes are unbiased, especially with the changes that we've had to put in place because of COVID, and how the assessment processes are unbiased. And there is a lot of work going on there. I think it's important to show people what we have done and to receive challenge about whether that was adequate and what more we need to do. And we heard that trainees would like forums to share experiences and concerns. And that's something we are going to ask our next group of trainee fellows to work with us on, because I realise that it can be challenging to raise issues. You can be concerned, especially if you're in a small specialty. And we need to make it safe for people to raise issues and concerns so that as postgraduate deans across the country and as a central team, we can act to address them. And one of the wonderful things we heard is that large numbers of trainees have done research into how to support trainees from different backgrounds, and they've offered to share that with us. And that's another thing that we will look at, collecting and summarising what information we have. And part of that tonight is Hatim's going to share some of the work that he's done. Now, I'm aware that I've just given you a list of issues which many of you are aware of, and maybe some of the trainees who've written to let me know about them. But it's actually just to highlight, we haven't finished the listening exercise, and that's what we're hearing, is to give you my commitment on behalf of me and the postgraduate deans that we are listening and we'll do something about it. And we'll come back to you to say what we have done and what progress we've made. We know we're not going to sort this quickly, but we are going to try and start making progress quickly. But I think there is a fundamental change in the NHS that's needed, and we want to work with you to make that change happen. So I'm now going to hand over to Namita to take us through the next section, where she looks at different experiences and different perspectives. So over to you, Namita.
Okay, so thank you very much, and hopefully, as if by magic, some slides will appear. So I think the first thing to say is inclusion and diversity mean different things to different people, and the solution will also be different to different people. But one thing that I think we're very proud of as English Deans is that we are diverse and we're cohesive and we're integrated and we work as a team. And I think in the NHS, we can't underestimate the value of that, particularly over the things we've had to deal with and see in the past few months. Now, I'm based in the North East. I'm also Regional Dean for the North East and Yorkshire. And those two lovely pictures there is one of Durham Castle and Cathedral and the Humber Bridge. And it's acknowledging our diversity within England, as well as all the other protected characteristics we're more familiar with. Can we have the next slide, please? So one of the issues we have is differing mortality. The slide on the left is life survival, life expectancy for men. My left, your right, and the other one for women. And again, this varies. And one of our key aims as doctors and healthcare professionals is to see how we can improve healthcare outcomes for all of our patients and populations. Can I have the next slide, Helen? So, not unsurprisingly, as postgraduate deans, we're very keen to know where the doctors are. This is an ongoing saga. We measure what we can measure, and these are GMC data, and we look at the number of doctors here and how that is different across the country and how that's changed over the past few years. Now, numbers of doctors alone are not the solution to improving healthcare inequality, but it can be a marker, it can be a proxy, and this also has to be part of the work that we do and are doing. Next slide, please, Helen. So what we've seen through COVID are the cumulative excess deaths. I think there'll be a lot of data and a lot of analysis and research to follow, and we are seeing that variation across our regions. And you will have seen similar figures, I'm sure, over the past few months. Next slide. I've always had this photo up framed in my office, and I put it up the first week I was appointed as a postgraduate dean. So you're either really lucky to be in my office or really unfortunate to be in my office. But for me, it's one of the reasons why I pursued a career in medical education, because I felt it was a way to deal with inequity and injustice. And a personal story from me is my mother's a doctor, and she was told in 1968, you're brown, you're a woman, just don't bother going to any further training. And that, that sticks and that has stuck with me. And then if we can move forward, Helen, the Black Lives Matter movement has really chimed so hard with so many of us over the past few months, and we had to acknowledge that this is a massive issue. And as Shona said, we want to find solutions because we know there are issues within our profession. Next slide. So this is a slide from, I think it's the King's Fund. We will share these. You can see the ethnic profile of NHS doctors in England compared with total population, and actually we're probably overrepresented, but it's worth knowing the actual data and the information. Next slide. The gender pay gap is a problem. This slide on the right is the Nuffield, and you'll be aware that Professor Jane Dacre has looked at this, and there will be work coming through this. This is a problem, and it is something that we've been aware of for a couple of years now, and we need to look at how we address them. We know there are potential issues with clinical excellence awards, how they're awarded, how they're judged, and certainly as a group of postgraduate deans, we have been looking at how we can help support our wider system in looking at all of these aspects. The general practice pay gap is 33%, which is far higher than the average in medicine. And when I was putting these slides together, that was a surprise to me, and maybe it shouldn't have been, but it was. We're not, as women, yet represented in equal proportions in senior medical grades. And I've certainly noted in my time as a consultant an increasing number of women believing they can't have a career and have a family in hospitals. Now, being a GP is an excellent thing, and women should do whatever they feel they're best suited to do. But not to be able to have children in one aspect of medicine, it's a concern, and that we need to address that. And 2/3 of doctors in training grades are women, and consultant grades, this drops to under half. So we do have some issues, and we do need to look at participation, perception, and concepts of what happens. Next slide, please. So we also have a issue in underrepresentation in senior management roles in the NHS. And I think if anything, this is a larger concern, which is why we do have the WRES standards that the NHS it's been promoting, it's been working on, but there is work yet to be done. So I thought this put some of our concerns and considerations into context of our wider teams within the service. The next slide, Helen. We've been very inclusive of gender and sexuality. That has been something we've worked very hard on over the past few years. This is from one of our local trusts, and I think that's great. I think many of our colleges are also using the banner, the NHS Rainbow. But the point of me using this slide here is we need to be inclusive of everyone, the things that we've legislated and stated as protected characteristics and the things that we perhaps might not have. And that's what we have to keep in our minds, that to be truly inclusive, you have to really value and respect everybody. Now, the next slide. So this is a question, I don't know if it would work, but the question here is, does anybody know who this selection of gentlemen are? And I think for the sake of all our sanity, we'll just move on and you can have a think about that. So have the next slide. And this was the Yorkshire Ripper Squad. And there was a documentary on iPlayer about how the way they thought meant that they were convinced that the Yorkshire Ripper was only interested in killing prostitutes, and actually women died because they didn't have a wider thinking in their approach to who that Yorkshire Ripper might be. And this is a very extreme example of what happens when we don't incorporate diversity in our thinking. We know there is very good evidence that women on company boards increases profit, as does having a wider ethnicity. The more diverse you're thinking, the more likely you are to be successful. And the evidence is emerging that this is in many areas, not just profit. And the next slide, please, Helen. So this is our HE data of BAME statistics against the WRES standards. So we're not just looking at training, we're looking at how we operate. And there will be a plan of work in the North to help us address some of this inequity. And I hope that that will feel better and will be more inclusive as we carry the work forward. Next slide, Helen. Next slide. No. I think we're nearly finished. I think that's pretty much my last slide in any case. So that was a good place for me to stop. So the message there is, in addition to us asking you, we are trying to be as strategic and as broad in our thinking as possible as we lead education and training in a very complex health service. So I'm happy to share those slides. I hope that was helpful, and we'll take questions, I think, at the end. So now I'd like to introduce Hatim. Are you still there, Hatim?
I'm here.
Thank you. So as Hatim said, he's a GP trainee. He's undertaken some research into some of these issues. So he's going to update us on that. So thank you, Hatim, over to you.
Thank you, Namita. So as Namita mentioned, I'm currently a GP trainee in North West London, and I also work part-time at the local university. And as Shona mentioned earlier, I was a clinical fellow at Health Education England last year. As part of that role at Health Education England, I was involved with the NHS staff and learners' mental health and wellbeing review. And part of the work that I did in that was to look at postgraduate learners, particularly from a racial discrimination, racial factors point of view, and think about what impact that has on the mental wellbeing of postgraduate learners. Following on from that, I got a chance to speak to lots of leading educators, leading academics, and leading policymakers who are involved within these issues and trying to make a difference. And it really got me thinking about what we need to do going forward. I had the opportunity to then carry out a workshop at the Leaders in Healthcare conference run by the Faculty of Medical Leadership Management last year. And this was a real opportunity to start to raise awareness of the challenges within Black, Asian, minority, ethnic individuals in healthcare leadership. Think about big room thinking to use to help design potential practical solutions. One of the things that is nice to hear from Shona and from Namita is actually what Health Education England is hearing through their sort of engagement work is very similar to the sort of discussions that we had within this workshop. And secondly, that actually some of the solutions that I'm going to discuss now are already sort of being thought about and actually being developed. So that's one thing to be really positive about, I think. But clearly there's a long way to go and there's a lot of issues that we need to tackle. We identified 4 key themes that we needed to sort of look at. And the first of these was recruitment. The second one was bullying and leadership. The third one was mentorship. And then the fourth was cultural awareness. And when we came to solutions, we really wanted to think about solutions based on the person, the team, organizationally, and the system as a whole. So let's just break that down a bit more further. So when we talk about cultural awareness, the problems that we sort of identified was that sense of exclusion that people from an ethnic minority background feel from that old boys network. And I guess this also really is relevant in terms of gender as well. And that sense of exclusion based on, based on the area that you work in or the organization that you're in or what you see from above can make it very difficult to then see yourself sort of progressing in the same way that you would hopefully expect your career to go. And that also then makes it difficult to sort of speak up and difficult to raise issues. One of the other issues is that feeling of disconnected identity, particularly in second generation, coming to third generation people from an ethnic minority background, is that disconnected identity between sort of what you've grown up and the color of your skin, all of those other factors, as well as the society that we live in as a whole, and how we're sort of expected to behave or expected to be. And that disconnected identity makes it very difficult to sort of be yourself often in a workplace setting. So how do you prevent that from being the case? Because that really should not be the case. And I think the key thing for us is to sort of get over this unwritten culture that we have that underlies things, and also think about how we challenge and raise discrimination in action. That there are no grey areas, in my opinion. I think it's very clear how things should be, and so we need to tackle that and call things out when they're wrong. So in terms of solutions within that area, we're thinking about how do you improve induction for overseas staff who are coming to work in the NHS, so particularly our international medical graduates who actually suffer from a lot of discrimination, bullying, harassment. What do we do in terms of team awareness, making sure that actually when you do join a team, you have appropriate social events, away days, check-ins, which are all inclusive, and actually give everyone an opportunity to attend and take into account what, some factors that might be important for someone from a different background. And so when we're organising these social events or these away days or these sort of factors that, as a GP trainee, we have away days all the time. It's just making sure that they're inclusive for everyone that is going to attend. And for that, you really need senior engagement. You really need your seniors above to be taking into account what is important to you or what factors they need to consider, and essentially leading from above. We then also need to look at sort of how we can actually act out some of the problems, some of the discrimination that we're seeing within the system. So things like workshops, role plays, having opportunities to actually play these things out, tackle things like unconscious bias. And I'm very, unconscious bias is one of those things that's bandied about, but I think it's important to, really think that actually unconscious bias is just unacceptable, and it's not something that we can hide behind. So having workshops where we can really play out these issues, tackle these issues, do role plays can actually really help. As Shona mentioned earlier, it's about making sure that we have a safe space for feedback, that's non-confrontational, non-judgmental, and really gives individuals an opportunity to call out problems that they see. And therefore, we need a toolkit for calling out discrimination that is non-confrontational, that there can be potentially anonymous if it needs to be, and can lead to the appropriate support from above if you are to call something out. Obviously, the next area that we looked at was looking at actually mentorship and leadership. Now, I think the key thing to still sort of mention in this area is that there are leaders from above that we can be inspired by. There are individuals that have broken that glass ceiling, but there's still not enough of them. All of the evidence that's been put out there by the Workforce Race Equality Standard or by individuals such as Roger Klein has shown that actually there's a dearth of BME leadership, particularly at senior management level, at board or executive level in the NHS. The proportion of BME staff in the NHS is 17.7%. Yet the proportion of BME clinical various senior managers is as low as 7.9%. And this is across the system as a whole. If we look at London, for example, the Black Asian minority ethnic population is 40%, yet boards just have a BME membership of 15%. So when one looks at their own organisation that they work in, be it the trust, or looks at sort of wider organisations across the healthcare system, they know that they're not really represented. Their values or what they believe in or what they stand for are not really represented at that level. So that's something that needs to be tackled. And this data is out there for everyone to look at. The Workforce Race Equality Standard will produce this data on a yearly basis, both in primary care and secondary care. So it's something that we really need to tackle as soon as possible. On the bright side, the Black, Asian, minority ethnic staff representation in leadership positions is increasing. It's on the up. But the current projections, it would be another 30 years before we reach that 40% mark that we see sort of representing the population of London. And as I mentioned before, it's about tackling that glass ceiling. Now, there are some current initiatives already in the system. So the Leadership and Race Equality Action Plan challenges all NHS leaders to address race equality and help to ensure that NHS recruits, develops and retains the best talent from all communities. Of course, the Workforce Race Equality Standard identifies these problem areas, publishes out there for all to see so that organisations can be held accountable. And Health Education England, BMA, GMC, many Royal Colleges have all published their own data which identifies problems around things such as differential attainment, recruitment, etc., so that we can take steps to understand the problems and how to mitigate them. And actually, of course, with everything that's happened recently, with the Black Lives Matter movement and the sad passing away of George Floyd in America, has really been a watershed moment for us to really think about how we need to do things differently. And as a result of that, I'm seeing with my own Royal College, the Royal College of General Practitioners is now a Black, Asian, minority ethnic action plan, which is coming out in the next sort of week or so. And these kind of movements, which are involving people who are, really passionate about these issues, can only be beneficial as a whole. So when we talk about inspiring leaders, our solutions really were in terms of zero tolerance policies for calling out, racial discrimination and problems, and actually saying to boards or organisations that, this is the sort of this is what you're showing to the rest of your workforce. Another thing is to look at what we can see abroad. So of course, there's a lot of talk about what happens in the USA, but actually, if we look at the USA, this has been called out for a long time, and actually, America has made a lot of progress in this area, often more progress than what we see here in the UK. There's also looking at industry as a whole, both abroad and within the UK, and seeing what we can maybe take from their approaches to what we can bring here to within our healthcare system in the UK. And it's about supporting individuals to be able to, have the skill sets to become senior leaders and to become even more examples to juniors across the system. It's about changing equality and diversity training. It's not just a tick box exercise that needs to be done online as part of your mandatory training for your trust. It actually needs to be really tackling and thinking about these issues and thinking about how we can be fearless in the future in progressing in these areas. So the key thing I think for us is to think about discussing this in a wider context. This isn't a healthcare issue, this is a societal issue. This is across, every workplace, every system in this country. So unless we actually think about it in that way, unless we have those conversations at home with our family members or with, when we're out with our friends, no matter what backgrounds we come from, we're never actually going to make progression. And the key thing for us is to think about the economic case. The evidence is clear. Having more diverse backgrounds, having more diverse staff, having more diverse leadership, all leads to better healthcare. It leads to better experience for patients, leads to more efficient healthcare as well. So from that point of view, there really isn't an alternative argument. When we talk about recruitment, we know that actually, if you're from a Black, Asian, minority ethnic background, the labour market in the UK is overall discriminatory against these individuals. And the distribution of BME staff in the NHS is completely disproportionate, as Namita mentioned, with gender, and it also applies to race. Doctors' staff grades, and doctors are more likely to be staff grades or staff associates or specialists, associate specialists, rather than be consultants. Or, if we look at what we see in the training grades compared to what we see at consultant level, there is a disparity there. And that also applies in terms of the actual pay gap. So whilst there's a gender pay gap, there's also a pay gap with ethnicity. And of course, if you're an individual who's from a Black, Asian, minority ethnic background and you're female, you're even less likely to be successful after an interview process. You're even more likely to suffer the discrimination that we see currently in the UK. So, we really need to try and bridge that gap. And that applies to recruitment and differential attainment in terms of exam performance. I mean, the key thing for me is to think about, whilst we know overseas international medical graduates might perform worse than their white counterparts in professional exams, but we actually see, first generation BME people who are born in the UK also perform lower in professional exams, both at undergraduate and postgraduate level. Again, there are initiatives to help improve this, and hopefully day will make some impact. But in terms of what we can do, I think quite clearly is just make people aware of the recruitment issues and make sure we have diverse panels, powers of empowerment to call out any discrimination or disparity within those panels that are interviewing individuals. And also have uncomfortable discussions with HR leaders to make sure we promote that culture of change. We can't hide away. Finally, looking at bullying and harassment, and this is probably the most difficult area to look at, really. Hierarchies are present within the medical workforce. It makes it very difficult to challenge and raise issues. If you are a junior doctor and your consultant is a white male who may have said something inappropriate, it's very difficult for you to feel comfortable with actually calling that person out because they're responsible for your training or for your progression, etc. Accent, language can all be barriers and can all lead to bullying and harassment. And then you've got those microaggressions. There's questions like, where do you come from? There's subtle pieces of undermining someone in the workplace. There's patient and staff bullying. And sometimes staff solidarity is not there when patients might say something inappropriate or refuse to see you because you're a Black or Asian minority ethnic doctor. And then there's the interplay of different relationships between the multidisciplinary working group. It's a very intense atmosphere, and sometimes that only exacerbates the problem. International medical graduates will come to the UK and often find it extremely hard to start to learn the system, start to understand the system. And as a whole, within the NHS, within the healthcare system, we're not always perfect, both working multidisciplinary within our doctors team. So actually, you know, from one medical specialty team to another medical specialty team, or from GPs to another medical specialty team, let alone how we are with our nursing staff, our advanced care practitioners, etc. So unless we really tackle those issues, we're not going to make progress in the area of bullying and harassment. And of course, there's a lot of internal work that needs to be done and is being done at the General Medical Council and other similar organisations. I mean, one key thing for me is, how is it possible that a trust can perform extremely well in their CQC rating, good or outstanding, but actually have poor workforce race equality standard outcomes? That to me does not make sense. So we need to be looking at the CQC well-led framework and making sure it factors in diversity and experience of the Black minority ethnic staff. And we need to make sure we have the appropriate processes to allow anonymous reporting of bullying and harassment and support individuals that suffer that bullying and harassment appropriately. I hope that a lot of progress will happen in this area, and I truly believe there has been a lot of progress in this area, even over the last few years. I feel like as a trainee, I was almost unaware of everything that goes on around you. I didn't really think about the bigger picture until I started looking into this work and actually getting involved with this work. But everything that's happened more recently has led to awareness of this issue. And I think as a result of that, we're going to start to see a lot more progress in the future. Thank you.
So thanks for that, Hatim. That was really good. And can I just say there has been progress. That certainly in my day, I probably did have differential attainment issues, but we didn't describe it then, we didn't know it then, but we do now, and that is progress. And though it doesn't always feel that way, I think we do need to acknowledge some of the really good work that's been done, so thank you. We're now going to go to my fellow postgraduate dean colleagues. I hope they're still here. So Geeta, are you here?
Yes, I am.
Great, over to you.
So yeah, I think that mine is been a very unusual journey. I started out my training in India, actually as an international medical graduate, as you would call it. And it's interesting, differential attainment doesn't actually belong to countries. It's there all over the world. So I still remember deciding that after doing my ophthalmology training, that I wanted to do retinal surgery as my subspecialty. And I went into the clinic the first day and was told by the professor there that I think that I should be changing my specialty because retinal surgery was for men. Female doing retinal surgery was not an option in those days. He told me to go and do ocular pathology. He said that was a good one, for a good subspecialty for females. So, it's interesting. And so I came into this country after having worked as a vitreoretinal surgeon, consultant vitreoretinal surgeon in India for 8 years, and came here because my brother encouraged me to come because he was here and said I should come and do the fellowship exams. I came here as on what was called in those days the double sponsorship scheme, which is now the MTI scheme, and started my job as an SHO. So from consultant down to SHO, brilliant progress. And then was doing my registrar job when I realized that things are not that easy, and trying to actually, get your son sorted as well as a husband who's working in London, and, juggling all these things and working your job, and decided that maybe I should just come out of training and take a substantive post where I can at least give some stability to my son. And so therefore went on to take what is now called a specialty doctor job, and in those days a staff grade job. And I remember my brother not talking to me for a whole week because he thought that, I had completely ruined my career by doing that. But I quite actually enjoyed that period in my life where I could actually do things that way I wanted, and I had created a niche for myself. I was lucky that, I had consultants around me who did not let me stay the way I was and forced me to go down the Article 14 route, which was what it was called, recognizing all my training that I did in India, and subsequently became a consultant. But it's interesting that, we've been talking about inclusivity, and, beyond inclusivity is what we call a sense of belonging. And sometimes that is what needs to happen, because people do think about the inclusivity in the large sense of the word. And I love this example of, describing what does inclusivity mean and what is the difference with sense of belonging. Inclusivity is actually being invited to the party, but actually the sense of belonging is when you're asked to dance. So, it's about that. So it's, kind of making sure that, the people. So what have I done? So in my journey, I've obviously come across loads of failures. And, when you look at your journey and you see all the leaders, you always think, oh, they've had a straight line up to the top. And that's not the case. And failure, as my mother always tells me, is a part of me. I can't actually take it away from me. But the important bit is actually to learn how you can actually navigate things. Remember going to a boardroom to present my project on developing a mobile macular unit. I was a junior consultant, and I was given 10 minutes on the exec board to do my presentation. 5 minutes into the presentation, I was told, oh no, this is not something that's going to work. I think it's, we don't want to go forward with it. And I'm sure that they were just judging me from what I was rather than what the project was, because I don't think any of them had even read what it was about. And I thought, I really think this is a good idea for patients, so I must take it up. So it's like Hatim was saying, how do you call things out? And how do you have that protection when you're calling things out, when you're still a junior consultant? Remember going to each and every person on the panel and explaining to them as a one-to-one what I was trying to do and why it was so important for the patients. And I remember going back the second time and, having the project approved. But, it had to be trying to navigate the system to make sure that you actually get where you want to be. And failure doesn't stop, even in your senior positions, you keep getting it. So remember going for this roles, where I thought, oh, this is where I can actually make a big difference in education, because as you can imagine, education is one of my passions besides research. And being told on a call that they thought I was overqualified for the role, when I thought I had aced the interview and was really pleased with myself about it. And so along that, I remember my friend telling me, rejection needs to be redirection. And of course, I have my mother at home, who absolutely quotes everything. And I remember her telling me something from the Best Marigold Hotel. She said, it always is all right in the end. If it's not all right, it's not the end. So don't worry, and she was right, because rejection was redirection in my case, because, a few weeks later, I got appointed as postgraduate dean and was able to do much more in the area of education than I would have done in the other role. But at that point in time, it's very hard to pick yourself up and then start all over again. But I think the things that I would really like to tell you is that it's really important to be authentic. Don't try to change yourself. Don't try to change your cultures and your values, because that's what makes who you are. And it's the who you are that's really important than what you are. So, if you actually ask me who I am, I'm actually, Geeta Menon. I'm a female, I'm a doctor, and I'm, a mother, a wife, of course, because my poor long-suffering husband. I'm a grandmother. That's who I am. And what I am is all those different titles. But if I actually live my life looking at what I am, then the who I am is going to, when the what disappears, the who will go down. Whereas, if you actually think about deciding what you want to do by acting, making your who-ness as that filter, and the values will then trickle down. Don't take roles where you are actually doing it for titles. Do it because you're really passionate about it, because you'll always succeed in the end. And having that passion, having that, perseverance, and making sure you really know where you want to be. And life, failure, like I said, is hard, but it is a part of you. Don't try to pretend that, you've never failed in your life. I think, that's really the wrong thing. What I've also learned is that, from all my experiences, what I tend to do, therefore, is actually try and make sure that I can create that belonging. I've made sure that lots of specialty doctors that I have worked with, I've all got to do Caesar, help them through that process. It's actually, sending that ladder down so that other people can come to where you are and supporting them in that process. The other day I read a quote which I thought was really interesting. It doesn't matter where you're coming from. All that matters is where you're going. And that is what you need to keep in mind when you're moving along. Try and find all those people who can actually support you. They call it sponsors these days. So, you have a coach who talks to you, a mentor who talks with you, and a sponsor is somebody who talks about you when you're not there. And it's those sponsors that you need, lots of those sponsors who can actually help you along in your journey. So I think, it hasn't been a straight line. It's been lots of, ditches, valleys, lots of alligators pulling you down, etc. But the important thing is to just keep going. Thank you, Namita.
Thank you for that, Geeta. Some great anecdotes in there. I love the one about being invited to the party and then being asked to dance. I love that one. And rejection should be redirection. So really, really great things to keep in your mind. Sanjeev, are you there?
Can you hear me?
We can.
Great.
Hand over to you.
I'm going to start with an apology because my technology is so poor today. I'm having trouble with connection. So if I do get cut off, I'm sorry. Yes, hello, my name is Sanjeev. I'm a GP in North London, and I come from an Asian background. I grew up in North London, but actually spent most of my formative years in India, schooling in India. Before returning to the UK for university, and in much in the way that Namita and Geeta have identified, there have been through my career microaggressions and situations where examples come to mind. Was when I was taken to one side and advised by one of my consultant colleagues that I must never think about applying for surgery, because I wasn't up to it, and particularly my background wouldn't give me the dexterity that was required. I've had that one. I've had a number of conversations where people have kind of sort of said, "So you're from the Middle East. What does it feel like to be a Middle Eastern individual?" So misunderstanding my background without actually inquiring about it is not an uncommon experience, even relatively recently. I think that there are some key learnings that I've taken away from my career over the years. And one of them is that actually living perpetually in a state of feeling as if there is bias against one's background generates a sense of fear. And that in turn, that sense of fear generates an inhibition to one's ambitions and one's aspirations. And I would urge anyone in that position to recognize that and seek to challenge oneself to go beyond the fear. There's an Australian saying, which is, a life lived in fear is a life half lived, and it comes from the movie Strictly Ballroom, and I strongly believe that actually one should recognize it and not be fearless, but to challenge that fear. As Geeta and Namita have suggested, seeking out your friends is really important. Your sponsors, those individuals that seek to understand one and help you get through difficult times, has been really valuable to me. I was really surprised that when I started to call things out around racism and bullying, people were genuinely surprised and welcoming of the feedback. So please don't hesitate to share what you might think is a negative experience. People around you will respond positively. They want to know. Often people don't realize that they're saying things that are hurtful, and by calling it out, you're actually helping them. So remember that actually calling something out is really important. I have found that using my culture and my background in my work has been really, really positive. It is a welcome thing to do, and it really helps inform that diversity of thoughts that Namita referred to. Thinking differently is helpful because it generates new ways of doing things. It creates solutions that otherwise people wouldn't think about, and it's really important. I would also just latch on to something that Geeta was referring to, which is that there is no such thing as a straight road. There are ditches, valleys, roads, and dirt tracks, which we all go through. And accepting that as a part of life is really important as well. And particularly because of the challenges that BAME colleagues in the world face, it is important to be accepting that that we will go through these difficulties, but it's how we work with them and work through them that is really, really important. But actually, the fact that actually HEEs, postgraduate deans, are a really, really rich collective of diverse individuals is a reflection of the fact that actually we are making a difference and making an impact, and our work is being, our backgrounds are being reflected in the way we work as well. So I hope that's helpful, and I would urge anyone listening to this to remember the stories that you're hearing today. It can be done. We can overcome this. Thank you. Namita, back to you.
Great. Thank you for that. The ditches and the roads are, I think, we're and the cliff edges on occasion. But thank you for that. I think really two really very different stories. One thing I would just like to say a bit about gender and a bit about, I mean, we talk about microaggressions and unconscious bias. So one thing I've noticed is it's a very small thing. It's titles, doctor, professor, and who gets one on their name badge and who doesn't. And if you say something, are you being difficult? Are you being a difficult woman? Or actually, are you just being acknowledged the way your male peers are? And this is something that's happened to me a lot. And you sort of sit there and go, do I say anything? Don't I say anything? And actually, I think we should. And you can pick when and how, but I think a lot of what's come through this evening is about how to challenge and when to challenge. But the important thing is that first of all, we recognise there's a problem. We have the confidence to challenge appropriately and professionally, as always. But also that if we don't have the confidence, that perhaps we start thinking about how we can help each other have that, because as Sanjeev says, if people don't know, we won't make this situation any better in the longer term. So I think this is the last bit on the inclusion. I hope that was helpful. I'm going to hand back to Shona now to answer the many questions that we've had coming in. If that's all right, Shona, over to you.
Thank you, Namita. I'm going to field questions, which is much easier than having to answer them all myself. So I thought I would start with the shielding questions, and I'll give them to Jonathan in clumps. The first question that he was asked, that has been asked, is can you appeal a non-progression outcome, an outcome 1 or a 10.1, if you've been shielding? So Jonathan, can I ask you the answer to that one? You have to wait.
Or a 1. Oh, sorry. I think you meant an outcome other than a 10.1 or a 1, and yes, it's subject to exactly the same appeal process as would normally be the case. I suppose the only difference in this virtual world is that the appeal would be virtually managed, but yes, exactly the same as normal.
Helen, are you coming back? Thank you, Jonathan. So one of the other questions, we have one from a trainee asking if they're a shielding trainee and they're coming back into training and concerned about how they're going to get their face-to-face competencies, and have worries about their risk, perhaps because of a BAME background. How are we going to address the need for them to get competencies coming back into work, having been shielding? And there's similar questions asking what will happen if you're going to start in foundation and you need to be shielding. What placements might you be able to have, or how are we going to address the fact that they might need to be working from home? And what would happen if you're starting training in August and you have been shielding? So sorry, I'm giving you 3 at once, but they're along a similar theme. So back to you, Jonathan.
Yeah, I suppose the questions bring up two different issues. First of all, there's the safety and the risk, which is something that has to be discussed with your employer, and you with your employer and occupational health advice will make a decision as to what the risk is. So the first thing is assessing the risk and assessing whether that's a risk that you and the employer think is one that you can take or not, and that's a discussion, and that's something that comes out of a discussion between you and your occupational health department. If you cannot do face-to-face consultations, then our job is to make sure you can gain as much as possible through virtual consultations. And we're all learning as far as virtual consultations are concerned. I mean, I've started doing for the first time over the last few months. It's difficult to learn how to do them, but also difficult to know how to supervise someone doing them from often from a completely different building, maybe even from a different city. And there are, of course, patient safety concerns, but that is really precisely the reason we're suggesting having lead shielding educationalists in each deanery, so they can actually build up some experience in this. They can learn from each other as far as best practice is concerned, and they can advise on the best way of doing virtual consultations, both safely and in a way in which you are going to gain as far as training is concerned. And that's, that will be work in progress. I think primary care is ahead of the curve as far as that's concerned, and I think there's a lot that secondary care can learn from primary care. The other issue, of course, that it brings up, and we have in the policy said that it's something we will be working with NHS employers on, is the equipment you get if you are doing remote consultations. And our feeling is we have to work closely with NHS employers to make sure that your trusts are able to provide you with the appropriate equipment. I'm sure there was another question there. When you attend interviews, they always ask 3 questions at once to make sure that you can remember them all, and I have forgotten the last of those, but Shona, maybe you can remind me.
Jonathan, can you?
Yes.
Thanks, Jonathan. It was the questions about what we would do about placements, making placements available for trainees if they're shielding in foundation, and what we would do with trainees starting in August who'd been shielding. And there is a point made in the Slido that it's important to note that shielding is going to be paused. The need for shielding may not have gone away because we don't know what's happening with COVID. So it's really just asking you, I suppose, are the postgraduate deans going to be working within all the regional offices to try and address these problems, which are often likely to be individual for trainees? And one of so there's that question, and there's the is there extra study leave budget for shielding?
Okay.
So the first one's more a rhetorical question.
Yes, so postgraduate deans will certainly work with you all to ensure that you can get them, that your program is arranged in such a way that you can get as much possible training, allowing for the fact that you're shielding. And I think the fact that, to some extent, I started my presentation by saying that, you know, maybe we should forget about the government definition of shielding, because actually we're talking about people working in a risky clinical environment, whereas shielding applies to the population as a whole and applies to the spread of virus within the general population. So whether shielding is paused or not, you are still going to you may still be at increased risk in your normal work environment. And I think that's a really important message to get across. So these will be ongoing conversations. The starting in August question, I suppose that's exactly the same as the foundation program question. It's about managing your training in the way that we can mitigate as far as possible the effects of shielding. And one of the things we've talked about in the document is the idea of kind of active program management to try and maximize the training opportunities for those of you that are shielding. And then the other question was about study leave. So as you know, study leave is available on the basis of you gaining competencies that you can't gain elsewhere. I would make the point that there's a huge support return to training program being developed around shielding, both supporting you and providing education and training whilst you're shielding and on return to shielding. And the guidance does point you in that direction. I think there'll be more about that on the support RTT website later.
Thanks, Jonathan. Okay, thank you, Jonathan. Well, Namita, I have a few questions for you about the training in private hospitals. There's a question, trainees normally have to have a thorough induction in their NHS trust. Will they need that for private hospitals? And there's also a question about what private hospitals are going to be used for. Are they going to be used for helping you catch up missed training opportunities? Are they going to become standard training environments, or are they just additional training opportunities?
So thank you for that. I'm all on, great. So yes, you should have an induction. It's a new environment. Inductions are there for patient safety as well as a GMC required educational standard. You can't work if you don't know where everything is, so you should have an induction. Independent sector opportunities are currently being used to ensure you meet your training requirements. Now, what that involves for a particular individual depends on your particular training needs and your program and how much you might have missed. We're not currently looking at delivering training long-term in the independent sector. We're working with COVID-19 the same way everybody else is. We haven't suggested it's an opportunity for every trainee, But if you feel you have training needs that would be better met in a independent sector hospital, I think the thing to do would be to get in touch with your clinical educational supervisor, who can escalate to your TPD and head of school, because there may be something we could do better. But currently it's largely about ensuring that you complete your training and you get access to the opportunities you need to do so. Did I answer them both?
Thank you, Namita. And one on study budget, which I know you thought you'd avoided, but Namita is our lead for study leave, trying to address the. So one of them was a question from TPDs. And the reason I'm passing it to you is because it relates to trying to get the competencies that people couldn't get in surgery because of a lot of the training opportunities. Will trainees and trainers be able to access study leave funding to do things like simulation and wet lab training?
Yes. Right. So this
it's coming to you now, Namita.
Thank you. The study leave budget is there, and the key about the study leave budget is that it's available for you to meet your curriculum requirements. So our statement is we're all still currently trying to be flexible to ensure you can access what you need to complete your training. Simulation and wet lab financing will depend very much on what you need to attain those training requirements, and it will be very much on your local facilities and what is available locally. There is an issue about simulation and wet lab about appropriate social distancing, and our simulation colleagues across the country are looking at this in quite a bit of detail. So the answer is, if you need it, there should be a way of providing it, but this will require local discussion with your usual educational structures, and the oversight is by the local postgraduate dean.
Thank you, Namita. Now, I think we've covered the questions on that. So some of the different points that we've had on inclusion, there's been a point which is historically discrimination has led to some leaving training, barring returning to training in a specialty. Is there any way of addressing this? And I think the first thing is to acknowledge that there is discrimination. I think the recognition that it is there now, and it may be one of the reasons that people left training. As Jonathan mentioned, we have a training package for trainees coming back into training called Support. And I hope that that would enable people who have left training to look at coming back into it. And a lot of the work that we have been doing with the Academy on how you transfer between training should make it easier for people to move between specialties. And I would hope that if you had always wanted to do something as a career and you felt you weren't able to do that because of discrimination in the specialty, that we might be able to help you find that that was the career you wanted and transfer back into it. But it's very much an individual thing. So for people who have less training, we would support them to come back in through support. I'd encourage them to reapply and hope that we can address some of the discrimination issues that made them leave. Now, one of the other comments we've had was the comment about reverse mentoring. And actually an acknowledgement that that places a burden on trainees and how would you support them. There's a question saying there are leaders with lived experience, why not just recruit them? But it came from the feedback we had that was that trainees need mentors and support, perhaps from peers when they're suffering from discrimination. And perhaps it can be two-way. Now, Sanjeev, would you be happy to talk about what you've learned from the looking at this in London?
Yes, I will try. Again, my apologies if my technology intervenes, but I hope you can hear me.
Yes, we can. Hang on. Helen's trying to move it over to you. Technology permitting.
I hope you can see me now as well. Yeah, we've had a program of reverse mentoring going on in London, where we've had people paired up to share experiences of what it is like to be from an ethnic background, and it's been really powerful, not only for those people who are needing to understand what it is like to come from a BAME background, but actually for those individuals who've given up the time and effort to explain what it is like to experience racism or gender inequality. And the opportunity to share that experience with someone has been incredibly empowering. It has given people confidence and a sense of unburdening that actually I was surprised to hear about, and actually was energizing. It gave people confidence to be able to speak up about those experiences and to share those experiences. So my sense is that actually it is less about needing support, but actually the experience of going through that journey in itself is energizing and empowering. And I would encourage anyone who is willing to share their story with another to help the other person understand what it is like to experience racism or gender discrepancy, to be willing to do so. Because actually, if you've got someone in front of you who is willing to hear about it, it is a mutually beneficial exercise. It's a mutually beneficial process, and all the evidence suggests that mentors benefit and mentees benefit. And I think I'll just stop at that point, if that's okay, Shona.
Yes, thank you. So Geeta, I was going to ask you, there's a question that says, how do you find mentors and sponsors who will support you? As you mentioned, you had to find them. So what's your perspective? And then I might ask Hatim and Harpreet for whether they think it's as easy as you think it is. But...
Thanks, Shona. Yeah, so I think going and finding those mentors and sponsors is something that happens in your journey. So as you go through your journey, you will find people who you think are actually going to be able to help you climb the next mountain, or go swim across the next ditch that you have to go through. And more often than not, these are people who actually, they don't even need to be of a similar background as you, but they actually understand that the problems that you're going through and how they can actually try and help. And it's been interesting that in my journey, Shona, it has not been people from my background that have done it. It's been people like my ex-chief exec, who was an absolute white male, who did it, and who was my sponsor, helping me in my journey, giving you that confidence that you can actually do it. Because sometimes, like Sanjeev said, when you inadvertently face these microaggressions, you start doubting yourself. You start feeling that that imposter syndrome. You absolutely embody that all over, you see. So it's actually, this is where it helps. So what we tend to do in education is that we actually, so Sanjeev was talking about what we're doing in London. So what we've done is we have actually got a scheme where we've put out people who say that they're happy to mentor or sponsor and then engage and try and help. So that's what we've been doing.
Thanks, Geeta. Thanks, Geeta. So Hatim and Harpreet, do you have a view on what it's like from the trainee perspective? I'll come to you first, Hatim, and then if we can ask Harpreet for his view, if you pass to him.
Thank you, Shona. Can everyone hear me? So it's an interesting question, and I think the first thing to say is actually just if you look around you, you'll find that actually, let's take away ethnicity, let's take away gender, you'll find that actually, if you look at your even just your leaders within your own departments, your consultants, your GP trainers, and then you got to your training program directors, all the way through to postgraduate deans, they're going to be trailblazers. They're going to be people that really set an example to you. And I think it's as simple as putting yourself out there and being confident enough to say, let's just have a chat, let's open up about something, or let's see if there's any shared experience there. And if you do find that is inspiring to you, just do not be afraid to contact them. And sometimes it's better to have that contact even outside the clinical or the educational space. So even if that means going for dinner or for a coffee or even for a walk, you know, just some area where you can just be away from, you know, all the problems that we might face in the clinical world or the educational world on a day-to-day basis, to actually have a bit more of a meaningful conversation, a bit more of a meaningful chat. And I think you'll find actually what I really do, you will ask you the right questions. I remember, Shona, one of the first times we sat down together and had a conversation, the first thing you asked me was, tell me about yourself, you know, and actually really sounded like you were invested in me. And that sort of thing actually does make a difference. If there's educators on the call as well, it's just making sure that you have that conversation with your juniors to say, you know, what makes you tick? What do you like? Tell me about yourself. How's your journey been up till now? Because that's the only way we can really, truly start to understand each other and start to learn off each other. Oh, and actually, secondary to that, there is a comment about sort of fees. So yes, we pay a lot of fees. RCGP, I pay for being a GP trainee, and obviously your colleagues in lots of different specialties will have similar fees that they pay. So what I would say is start making the most of that money that you put into that organization, and actually look at what they're doing. So you'll find that most of these organizations, most of these faculties or colleges are actually doing some sort of, be it reverse mentoring or mentoring program to help support their juniors, and you just maybe don't know about it, or if they're not doing it, get an email out to them and say, let's set it up, because it just needs to be done. That's the only way you're going to actually get to make the most of those £400–500 that you're putting into your membership fees every year.
Helen, can you go to Harpreet?
Yes. Thank you. So, you know, building on what Geeta and her team have said, I mean, you know, I think one of the things that's clear is that, you know, we all meet interesting people along the walks of our life in all sorts of ways. And for me, really, it's just being honest to people and saying, look, you know, I feel been inspired by you. I think, you know, you've done great work. Can I request you to spend a bit of time with me and talk me through your journey, talk me through what you've done and how you've done it, and having that open, honest conversation. I think, you know, often going with too many expectations can lead to disappointment, because a lot of people have their own priorities, have their own ways of working, and I think this is just about getting to know the other person. But I think through those conversations, one also finds that he or she gets to know themselves. And I think that's often also a very useful way of doing it, is that by holding up a mirror, by having those conversations, you reflect, and then you realize a lot about yourself and your values and your, you know where you sit and how you think about things. And I think that's also a very useful way of looking at it. And, you know, like I said, more often than not, the vast majority of people I've asked to help or be mentors or sponsors have said yes, actually, because a lot of people want to help. A lot of people want to help, and a lot of people want to support. But I think often the biggest hurdle I find when I speak to either trainees or other colleagues is that they're just too afraid to ask. And I think if you never ask, you'll never know. And so, you know, the worst thing they can say is, sorry, I'm busy, but let's catch up in the future. But 9 out of 10 times, if not more than that, they'll say yes, they would love to grab a coffee and keep in touch. And I think that way you build the relationships, you know, and through open, honest conversations, it can lead to something very meaningful, which in my experience has been tremendous, both in the clinical side and the non-clinical side.
Thank you, Hatim, and Harpreet, for your insight from the trainee perspective, as well as from Geeta's wisdom from someone who's getting to the top. There's one other question, which is the guidance about shielding going to be, and what is going to be the norm for rotations? And I think one of the things is trainees are rotating in August. With individuals, we are going to need to, as Jonathan said, look at individual risks. And we're going to have to accept that the norm is not going to be normal for some time, and that we will continue to look at risks. We will look at risks at each rotation dates if there are further surges of COVID and if they're local. And so part of the message I'd like to give you is that we accept now that things are changing much more in education and training than they have done. We've had to change some things fast, and some of what has happened with the COVID pandemic has highlighted things like the inclusion issues that we've mentioned tonight. And I hope it's made everyone much more aware of the need to listen and act. And we're grateful to you for tuning in and listening. I hope you've found it informative, and we've helped with answering some of your questions. I'm going to ask Harpreet a kind of rhetorical question, but I'm still going to ask him it. As one of our board members, I'm hoping, Harpreet, that you will feed back on some of what you've heard and seen people ask tonight, and make sure that this remains a key priority at the board, which I know it is at the minute.
Yes, Shona, absolutely, and that's a commitment that we're willing to make and say that that's an absolute key priority. And I see this as one of many webinars we will be doing in the future and coming months. And I think it's an absolute priority. And if an organisation demonstrates this from all the way from the senior leadership downwards, I think it's really important that it does that. So it's been a tremendous evening by listening to everyone's views and points and all the questions asked, and that certainly be fed back. And I hope we can meet all again and talk through many of these issues again, and also, like you said, action them so that we can take a lot of this agenda forward and make a difference. So thank you.
Thank you, Harpreet. And I suppose the reason for coming back is to tell you that we've actually done something. It's no good just listening if we don't act. And Namita, is there anything you wanted to say finally on behalf of your other postgraduate deans, having coordinated us having a conversation?
So I think I'd like us to end on a positive note. I think it's been very interesting, and I've thoroughly enjoyed doing the webinar, and this is my first in this format, so I have thoroughly enjoyed it. I've thoroughly enjoyed learning more about colleagues that I've worked with for a while and new colleagues who I haven't worked with that much, and that's been an eye-opener. And I think the thing to take away is the role models are there, the support is there. We need to look at the good as well as the bad, because there's lots of good, there's lots of integration, and I think this should go some way to reassuring people that in postgrad medical education and training in England, the commitment's there to make this better training for everyone. So thank you.
I don't think there's anything more I can add. Thank you, everybody, for watching.